Welcome back to another episode of Microbiology Bootcamp. My name is Dr. Paul Bolin, and I will be your guide as we talk about the alpha-hemolytic strep. We will talk about one group and one bacteria aside from that group. So let's get started. If you haven't had the opportunity yet, please consider subscribing to my Patreon at www.patreon.com/pwbmd. You can get there by clicking the I button on the upper right hand corner of this video or in the description down below. If you'd consider chipping in $1 a month, a little bit goes a long way to help keep these videos free. I know that there are a lot of subscription services out there that can cost hundreds and hundreds of dollars. I am of the belief that all medical review videos and resources should be free, because we take a Hippocratic oath, and one of those components of the Hippocratic oath is that we will train our successors without the expectation of recompensation. So I believe in making free resources. That said, I do appreciate all the help I can get. These videos do take me away from my family and they do pose a slight financial burden on me. So any money to offset that, I genuinely appreciate. If you can't do that or alongside it, please go ahead and subscribe to my videos, and you'll get notifications as they come up. So thank you very much in advance. All right, we're not going to go into this in too great of detail. I talked about it in the gram-positive overview section. I just want to point out gram-positive cell walls are very thick with peptidoglycan. Gram-negative cell walls, they have two double phospholipid bilayers, an outer membrane and a plasma membrane, and a very thin peptidoglycan layer. Gram staining is the most important component of laboratory biology. It helps us divide things into gram-positive and gram-negative, gram-positive being purple staining, gram-negative being pink staining. There are other bacteria that are gram-indeterminate, acid-fast, other stains available for those. There are tons of stains that you can do in microbiology. Gram staining is the most important. I talk about it in the overview video. Please go back and look at that if you haven't yet. Remember that gram-positive are all purple, gram-negative are all reddish pink. So we're going to talk about the alpha-hemolytic strep. That is the Viridans group and Strep pneumoniae. We'll talk about the classification, what makes these distinct from one another, what makes the two of these distinct from all the rest of the gram-positive bacteria, some of the characteristics, virulence factors. Neither of these have toxins, but you will want to keep that in mind as we talk about other bacteria. I've got a nice cheat sheet to compare the two, and then a question that will help you see what you've learned. Okay, I don't have an illustration for this. Maybe I'll make one in the future. I don't want to let illustrations hold me back from getting to you these videos in a timely manner. I am not an artistic person, so I try my best, but I'm just not. That's just not who I am. I desperately wish I could be. My dad is a great artist. My sister is very artistic, but I did not inherit that gene at all. So maybe I'll get some more out to you in the future. This is our gram-positive algorithm here. I simplified this down just to detail out the gram-positive cocci, which is what we're talking about. Remember, as you're going through your algorithm, you're going to need to know this down cold because they may tell you a description of a bacteria and you'll need to know what it is, or vice versa. They'll give you a vignette. You know what the bacteria is, and you'll need to be able to describe whether it's catalase positive or negative, oxidase positive or negative, alpha, beta, gamma hemolytic, and so forth. So you'll need to know this cold. We're going to talk about the cocci here, and in particular, everything that is not catalase positive. Remember, catalase positive, synonymous with staph, catalase negative, synonymous with strep. Okay, so narrowing it down to our streptococci. Streptococci form chains. Staphylococci form clusters. So even without knowing the catalase test, you should know the arrangement. So all streptococci form chains, or at least pairs. We're going to be talking about alpha-hemolytic, and that is Viridans group strep and Strep pneumoniae. Okay. So all Viridans strep and Strep pneumoniae are catalase negative, like all strep, and they are also alpha-hemolytic. That's the name of this video, alpha-hemolytic strep. What is alpha hemolysis? So basically it's just partial hemolysis. What we do is we plate the bacteria, grow it on 5% sheep blood agar. These are red blood cells that are on there. The bacteria can interact with these blood cells. Some bacteria will completely destroy the red blood cells. That's called complete hemolysis or beta hemolysis. What we're talking about here is alpha hemolysis, and that's a partial hemolysis. So what happens is that the red blood cells kind of leak out some of their material, one of those things being hemoglobin, and then hydrogen peroxide within the bacteria will break the hemoglobin into methemoglobin, and methemoglobin has a green color, so you can see that right here. And alpha-hemolytic strep are not the only alpha-hemolytic organisms, but if you know it's strep and you know it's alpha-hemolytic, then you've got it narrowed down, right? So, as mentioned, alpha-hemolytic strep are gram-positive cocci in chains. They're catalase negative, unlike Staphylococcus. So, if you get catalase positive, then you know you're dealing with staph. If it's gram-positive cocci. Partial hemolysis causing a green color on blood agar. They are all facultative anaerobes, and then this is the big thing here, optogen sensitivity. So remember, in the staph section, we talked about novobiocin sensitivity. Here we're talking about optogen sensitivity. So if you're dealing with alpha hemolytic strep, your very next test is going to be an optogen sensitivity test because that will narrow it down to either the group or the bacteria. So if it is optogen resistant, in other words, if you put an optogen disc onto the plate while you're culturing, growing the bacteria, and the bacteria grow around right next to the disc, then you know you're dealing with Viridans group strep because it's resistant. If there is a zone of clearing, a circular zone of clearing around the disc, then you know it's optogen sensitive. The optogen is killing the bacteria, and in that case, you're dealing with strep pneumoniae. So the mnemonic is overpass, OVRPS, Viridans resistant, pneumoniae sensitive, O standing for optogen. So what are you dealing with here? So here's your optogen disc, and here's all your bacteria. This is optogen sensitive because you have a zone of clearing here. So optogen sensitive is overpass, PS. Pneumoniae sensitive. This is strep pneumoniae. All right, Viridans group strep. So there are 3 species that are important: Strep mitis, Strep mutans, and Strep sanguinis. Viridans group strep are part of the normal flora of the mouth, so it's very important when you're talking about dental procedures. It is bioinsoluble, so it can grow in bio, and it does this by hydrolyzing a component called esculin. That is not important for our purposes here, but it is a tidbit that can come up on the test, so I bring it up. There are a couple important virulence factors. First of all, Viridans group strep can form biofilms on dental enamel, and biofilms are just colonies of bacteria that are linked together by polysaccharides and gelatinous material, basically, that allow the colonies of bacteria to be resistant to immune cells or to antibiotics. And so this is a virulence factor because it allows the bacteria to create colonies and then cause infections. Viridans group strep also has the ability to form dextrans from glucose and sucrose. And so that is important because it allows it to become adherent to different things. So the diseases caused by Viridans group strep are dental caries. What happens here is the Viridans strep begins to adhere to the enamel on the teeth. This is why it's important to brush your teeth to prevent any of these colonies from adhering to your enamel. If they are allowed to adhere to the enamel, they form these biofilms, which eventually then, through bacterial metabolism, will wear down the enamel, ultimately wearing down the bone of the tooth, which then causes a cavity. That's what a dental carie is a cavity. The other thing that's more likely to come up in the USMLE is subacute bacterial endocarditis, and this only occurs with diseased valves, and Viridans group strep is the #1 cause of subacute bacterial endocarditis. What happens here typically is that a patient has a diseased valve, they go into the dentist, they have dental work done, there's a little bit of bleeding that happens, and then the normal Viridans strep from the mouth gets into the blood, causes a transient bacteremia, and for most people that would be fine. It goes away. For people with diseased valves, that bacteria will go to the diseased valve in the heart, and typically it's the mitral valve, most common valve diseased, and it will adhere to the platelet fibrin aggregates that already exist on that valve. And now you have an infected valve, and that valve can now become further damaged. Okay, so that's where its ability to form dextrans, which are really just glue for the Viridans strep. That's where that comes into play. So the biofilms and the ability to form dextrans. And this is why dentists give antibiotic prophylaxis to patients with specific valvular disorders prior to doing dental work. So bacterial endocarditis has mnemonic bacteria from Jane. This is obviously a microbiology talk, not a pathology talk. So I'm not going to go into this, but I do have other videos geared towards step 2 and 3 where I do talk about bacterial endocarditis, so you can go back and look at those videos there in the cardiology section. Strep pneumo. So this is part of the normal flora of the nasopharynx and the upper respiratory tract. Unlike Viridans group strep, it is bile soluble, so it does not grow in bile. It gets broken down in the bile. Couple important virulence factors. First of all, unlike Viridans group strep, strep pneumo is a very, very, very important encapsulated bacteria. One of the most important encapsulated bacteria. It's got a polysaccharide capsule. Strep viridans is not encapsulated. Also, strep pneumo has something called IgA protease. This is IgA down here. And IgA, remember, is a very important mucosal antibody. And what IgA protease does is it breaks it down. Now, normally IgA is on mucosal surfaces and it protects the mucosal surfaces from being colonized by too much bacteria. If something can break down IgA protease, it has enhanced colonization capability of the mucosal surface. And you'll see that the diseases caused by strep pneumo are all on mucosal surfaces. So the mnemonic for diseases caused by strep pneumo is MOPS, M-O-P-S, MOPS. And that is meningitis, bacterial meningitis, for which it's the #1 cause in most age groups. So we're not talking about neonates here. That's group beta hemolytic strep. So we're talking about most age groups, adults, older children. So that's bacterial meningitis. O for otitis media, #1 cause. P for pneumonia, bacterial pneumonia, in particular here the community-acquired pneumonia. Strep pneumoniae will cause a lobar pneumonia, and that stands in contrast to things like mycoplasma pneumonia, for instance. And then sinusitis, #1 cause of bacterial sinusitis. So another term you may hear thrown at strep pneumo is diplococci, and that's because there's a propensity for two, not several, but two separate cocci to come together and form a 2-cocci chain. So you may hear strep pneumoniae referred to as gram-positive diplococci, and so you want to put that term into your memory because that's very important. You'll see here that most of these are in pairs. Okay, pairs of cocci. And occasionally some of them will have 4 or 5, but in particular, strep pneumo has a tendency to form pairs, diplococci. And you'll also hear it referred to as lancet shaped. You can't really see that here, but you can see it here. Notice how it's got a little a pointy edge to it, kind of looks like a dagger or a knife. That's where they get the name lancet shape. And also know that there is a capsule, polysaccharide capsule. Please remember the big mnemonic here, overpass. So you're dealing with alpha-hemolytic strep, you got to do your optogen sensitivity test. So I put this picture here of an overpass in between these green mountains. Remember that alpha-hemolytic bacteria will form green areas on the agar, on the blood agar. So this green mountain overpass here, OVRPS, optogen sensitivity test, Viridans resistant, pneumoniae sensitive. Here's a comparison of Viridans and strep pneumo. Please commit all this stuff to memory. Very, very important stuff here. I'm not going to reiterate it here, but I do want to talk about very briefly the treatment. You don't need to worry about strep viridans treatment for our purposes here. There's a lot of disagreement on how we treat endocarditis, but for the most part, if you do need to know anything, beta-lactam antibiotics are pretty good. The penicillin, amoxicillin, stuff like that are pretty good. But sometimes there can be co-infections with MRSA, so it gets really complicated. So you shouldn't be asked about that on step 1. You could be asked about strep pneumo. And so the treatment for strep pneumo is azithromycin or ceftriaxone. Now, again, when you're doing empiric treatment for, say, pneumonia, you may be adding other things. So, for instance, if you're dealing with a small baby, you may add ampicillin because listeria is a big cause of meningitis, for instance. So, meningitis, pneumonia, there are because you're treating it empirically, you may be adding additional things to this. But for the strep pneumo component, it's either azithromycin or ceftriaxone. Also, a vaccine is available for strep pneumo, the pneumococcal vaccine. For adults, it's a conjugated vaccine. Remember, conjugation is very important for the component vaccines. You don't need to conjugate it, but we often do. And the reason that we do is because if you just gave the polysaccharide component, it would not be able to be taken up into antigen-presenting cells and displayed on the MHC class II. And you need MHC class II to interact with T cell receptors, which is something that needs to happen to release cytokines in order to induce class switching, so that you can make IgG antibodies, for instance. If you don't have that, if you just have the polysaccharide, you can induce a T cell independent immune response, but that is only capable of producing IgM, so it's very short-lived. We do have an unconjugated polysaccharide vaccine that we do give to children for pneumococcal vaccines, but for adults we always give the conjugated pneumococcal vaccine. All right, let's finish up with a question. We got a 20-year-old man presenting to the clinic complaining of a fever and purulent nasal discharge for the last 5 days. His past medical history is significant for a blood disorder, which has generally been well managed, and he has no complications in several years. He says that this is not the first time he's had these symptoms, and he's been discharged with an antibiotic each time, which has resolved the problem. Physical exam reveals maxillary tenderness on palpation. Which of the following standard interventions may have been helpful at reducing the risk of this patient's problem? A component vaccine, B, a killed vaccine, C, a prophylactic azithromycin, D, prophylactic amoxicillin clavulanate, or E, routine at-home nasal lavage. All right, so I'll let you pause here, and we'll go straight on to the answer. And the answer is a component vaccine. So what does this guy have? Well, he's got sinusitis, you know that, because he's got purulent discharge, he's got maxillary tenderness, he could have frontal tenderness if it was frontal sinus, but facial tenderness plus purulent discharge plus a fever equals sinusitis, without a doubt. But underlying that, he's got a blood condition, and what blood condition puts you at risk for something like this? It would be the famous... Come on, you know this. Sickle cell disease. Sickle cell disease causes you to autosplenectomize fairly early in life. And your spleen, as you know, is important for fighting encapsulated organisms. What's an encapsulated organism that causes sinusitis? Strep pneumo. He would also be at risk for meningitis. He'd be at risk for pneumonia. So he's got a decreased ability to fight off encapsulated organisms, and so he's going to be at increased risk for all of that. So the important thing is that you give him the pneumococcal vaccine. Pneumococcal vaccine is a component vaccine, as we already talked about. Killed vaccine, that's things like polio, certain influenza vaccines. Those are killed, not pneumococcal vaccine. It's a component vaccine. Prophylactic azithromycin would not be indicated. It probably would have prevented it, but that's not something that we do routinely. Prophylactic amoxicillin clavulanate, again, we don't give prophylactic antibiotics routinely to sickle cell patients. And then routine at-home nasal lavage. A lot of people get those neti pots. I don't recommend those. And there's risks with them. They may help with symptoms, but remember, what's one of the big problems when you pour water into your sinuses? Well, if the water's not treated, you run a risk of contracting Naegleria fowleri, and that causes primary amoebic meningoencephalitis, the brain-eating amoeba, which you hear about in the news every now and then. So that would not have helped this patient's problems. It may help his symptoms, but the answer to this is a component vaccine. So with that, I will see you next time.